Ebola viral infection is obviously an important communicable disease right now, and this is a very timely issue. And so we're lucky to have Dr. Kershke here today to talk about it and kind of get us up to date on what's going on with the epidemic and what we need to know as healthcare workers to prepare ourselves for it so we don't make any of the mistakes that we've seen in other places throughout the country and throughout the world. So Dr. Kershke went to medical school at University of Florida and trained in family practice in Florida. He spent 2 years as a commissioned officer in the Epidemic Intelligence Service with the CDC prior to joining the Tennessee Department of Health. He has investigated bioterrorism-related anthrax as well as the SARS problems that we had on airlines a few years ago. He spent 4 years as Assistant Medical Director of the Northeast Tennessee Regional Health Department and 3 years as the Deputy State Epidemiologist in Nashville at the Tennessee Department of Health. He's currently Medical Director of the Northeast Tennessee Regional Health Department, where he oversees communicable and environmental diseases as well as emergency preparedness and also primary care and dental services. He's adjunct faculty at ETSU in public health. His title today is Ebola Virus Disease Preparedness for Healthcare Providers, and I thank him for coming today.
Thank you. Thanks for everyone for coming. Some of you may be aware that we did a tabletop exercise with all the area hospitals on Friday surrounding the scenario of a patient showing up at one of our hospitals with Ebola. We know that this is a definite possibility. Don't have to, well, first of all, I guess I have to go through disclosures for the CME. I don't have anything to disclose, but I don't think we have to convince people that it's a real possibility that we could see a patient showing up with one of our facilities with potentially an infection that could be Ebola. You all know there's a patient currently being treated in Dallas with Ebola. We also know that there's many travelers. This outbreak is so big in West Africa. There's many travelers that go from West Africa and come to our communities. And we do know that there's people in Tennessee that have traveled to these areas. So it's a very real possibility we could see a patient. So I'm going to talk a little bit about Ebola virus disease. Then I'm going to talk about evaluation of fever in someone who's traveled, or more specifically, eliciting a travel history in someone that presents to one of our offices with fever. Go over the CDC Ebola evaluation algorithm. So what do you do with a patient who has traveled and is febrile, may have been in West Africa? And then go over a hospital scenario, a patient that shows up at the hospital with an illness that could be Ebola. And then talk a little bit about some CDC guidance on preparedness. So Ebola virus disease, currently the largest outbreak in history is occurring in West Africa. Now there's over 7,000 cases with about 3,400 known deaths. There are some estimates from mathematical modeling and things like that that say that this might be underestimated by a factor of 2.5, so it may be 2.5 times that. The history of Ebola first emerged in 1976 with outbreaks in Democratic Republic of Congo and South Sudan. In history, there's been 20 known outbreaks plus 4 sporadic occurrences of disease in 10 different countries in Africa. Up to this current outbreak, there was about 3,200 cases with about 2,000 deaths. So this outbreak's already exceeded all the known cases and deaths throughout the history of Ebola. Transmission, the natural reservoir is not 100% known, but it's thought to involve fruit bats. Some other animals in Africa may be infected as well. And likely the first patients are infected through contact with animals. But after that, human-to-human spread can occur. It occurs through direct contact with body fluids, including blood, urine, sweat, semen, and breast milk, or objects that are contaminated, such as needles. So again, the ecology, it's thought that fruit bats are probably the reservoir. Other animals could be infected, and then humans come in contact with these animals and can get the virus. Symptoms of Ebola virus disease: fever. So unfortunately, pretty nonspecific, especially in the beginning, and it's coming up to cold and flu season. So fever, headache, and myalgias can progress to diarrhea and vomiting, and then also progress further to abdominal pain and hemorrhage in some cases. The typical incubation period is 8 to 10 days, so after contact, people generally get sick in about 8 to 10 days, but the range is from 2 to 21 days. So you'll hear a lot of the recommendations are that people that travel to these areas or may have had contact with someone with Ebola virus disease monitor their symptoms for 21 days, so that incubation period is where that recommendation comes from. People are infectious while they're febrile, so before people develop fever, there's no known transmission of the virus, but after fever, the infectiousness increases as the disease progresses. So the sicker the patient, the more viremic the person is and the more risk for transmission. Can also be transmitted post-mortem, so a lot of the outbreak may have been fueled by practices among burying the dead in West Africa, so there's a lot of customs around placing hands on the deceased person to say goodbye and things like that that may have increased the spread of the disease. There's also some question after resolution of the illness, certain body fluids can continue to be infectious for a period of time. I know that the patient that was the doctor that was treated at Emory, he was in the hospital for about 3 weeks, and for a while after he had recovered symptomatically, just while they were monitoring so that no further virus was detected in his blood. So pathogenesis, it enters through mucous membranes, breaks in the skin, or parenterally through something like a needle stick. So it is not airborne spread. Can infect many different cell types, migrates to the liver, lymph nodes, liver, and adrenal glands. Lymphocytes undergo apoptosis, so you get lymphopenia. You can have hepatocellular necrosis, adrenocortical necrosis, and release of pro-inflammatory cytokines causing ultimately multi-organ failure and shock. Some of the laboratory findings associated with Ebola virus disease include leukopenia initially. Eventually, they say you can get a increase in neutrophils in the left shift, but the initial findings might be lymphopenia, decreased platelet count, elevated liver enzymes, AST greater than ALT, proteinuria, and then prolonged PT and PTT consistent with disseminated intravascular coagulation. Hemorrhage is not universally present, but it can manifest later in the illness with things like petechiae, bruising, oozing from venipuncture sites. Frank hemorrhage is less common. About 18% of patients in the current outbreak will develop frank hemorrhage, most often blood in the stool. So evaluation of suspected patients. So if someone presents with any febrile illness, one thing to find out about is epidemiologic risk factors in the last 3 weeks, so that 21-day incubation period. Have they had contact with an Ebola case? Have they traveled, probably more importantly, have they traveled to, more important first question, have they traveled anywhere? And if they have, is it to one of the countries where there's a current outbreak? There's also some risk to laboratory workers from handling animals that are endemic to that area. The other thing that's important to evaluate is, a febrile traveler, there's a lot of other things they are more likely to have than Ebola. CDC has evaluated probably 20 or 30 patients, probably more by now, that have traveled from West Africa, come back, developed a fever, and got admitted to the hospital. There's the one case of Ebola, but all the other cases had things like malaria and other travel-related illnesses, or potentially something more mundane. Like I said, we're coming up on flu season, so it could be influenza. So infection control, obviously a single room with a private bathroom. For Ebola, airborne precautions are not necessary unless you're doing an aerosol generating procedure like bronchoscopy. Nebulizer treatments are airborne aerosol generating, so things like that, or CPR, or intubating a patient. Standard contact and droplet precautions. So again, Ebola, you don't necessarily need airborne precautions. A lot of people do recommend wearing the N95 respirators because there can be aerosolization if you're doing an aerosol generating procedure, or if there's copious amounts of vomit or diarrhea, or you're doing environmental cleaning or some procedure where you may aerosolize some of those body fluids. Diligent environmental cleaning and disinfection, we'll talk more about that. And then safe handling of potentially contaminated materials, obviously. So patient placement and care considerations. So once you've isolated the person, so a typical scenario is going to be someone comes in with fever and a travel history. We're not initially going to know if that's Ebola or not, but you may have a suspicion, hopefully, if they've traveled to those countries or have actually had contact. Maybe they went to visit a family member who was sick with Ebola, something like that. It may take up to 3 days for testing to be positive for Ebola. So the PCR test can be negative for the first 72 hours of the illness. So if someone presents early, their first test is going to be negative. You'll have to retest them in 72 hours. So we're going to want them in a place where they're isolated. Maintain a log of all people entering and leaving the rooms, which will be important for follow-up. You want the fewest number of people possible going in the room. Use dedicated, disposable medical equipment if possible. Limit the use of sharps to therefore limit the potential for percutaneous injuries. Again, limit phlebotomy and laboratory testing to essential diagnostics. Carefully dispose of sharps. And then it's important that whoever's doing the environmental cleaning also wear the same level of PPE that's being recommended for the healthcare providers. So, again, contact precautions are important. Unfortunately, we're not always that great at doing contact precautions, as evidenced by the epidemic of C. diff in hospitals, which are at historically high levels. And C. diff is, contact isolation is what's recommended for C. diff. So it really requires strict adherence. And when healthcare workers are going in and out of rooms, tens, hundreds of times a day over a 12-hour shift, sometimes it's easy to lapse a little bit on PPE. So it's important to pay strict attention to that. So treatment, unfortunately, there's no specific treatment. Supportive care, there are several investigational therapeutics in development, but none have been tested. And CDC recommends contacting the manufacturer or the FDA regarding those. So initial patient management, consult with the health department so we can arrange diagnostic testing for Ebola while you're doing other testing for things like malaria and blood cultures. It could be something like a bacterial infection or sepsis or influenza potentially. Provide aggressive supportive care, assess electrolyte abnormalities, and then coagulation parameters. I don't know, the last bullet, it says consult the health department regarding other treatment options, but it's not like I have any secret remedy in my back pocket. But there may be ongoing trials going on in different places. So we would communicate with CDC. There's no approved vaccines available, although there's several investigational vaccines in development, and some phase 1 trials are underway for some vaccine candidates. If anytime, feel free to stop me or ask questions as we're going through this. I'm sure there'll be some. Yeah, so just because they have malaria, you don't want to stop testing them for Ebola, but you also don't want to not test for malaria and then they die of malaria while you're sitting there waiting for the Ebola test to come back, or from sepsis, or I think that's also in the meningitis belt. I'm not sure, but meningococcal meningitis or something like that. So at this point, we'll discuss a little bit about the evaluation of a febrile traveler, or evaluation for travel history in someone that comes in febrile, which probably should be a question at this point asked of anyone that comes in febrile. So there's no stereotype person that you can say is at risk for Ebola. We have missionaries that are traveling to West Africa and coming back to our communities, people that are from here. Obviously, we have immigrants that may travel back and forth. So it would be hard to there's not, just by looking at someone, you're not going to be able to tell if they traveled or not. So the Tennessee Department of Health put out this document, and there's copies in the front of the auditorium there on the table as you leave. But it's heightened awareness for communicable diseases. This came out back in August, mainly because of concerns about Ebola and also MERS, which I'll talk about briefly, what that is. But basically just encouraging clinicians and people in the ER and hospitalists and things like that to ask a travel history in anyone that has a febrile illness. There's other things going on. There's a huge measles outbreak going on in the Philippines, of which we've had people travel from there to here, and there's been cases of measles in Tennessee recently. And then there's also been people traveling to the Caribbean coming back with chikungunya virus. So travel history is always important when someone with a fever. So Tennessee Department of Health guidance is if someone presents with fever, ask about international travel in the last 30 days, or exposure to someone that's sick that's traveled internationally. So it could be a secondary case. If yes to international travel, place a face mask on the person if tolerated. This would protect against airborne things like measles or MERS, which we'll talk about in a second. And then put them in a negative pressure isolation room if there's available. If not, just a closed, private closed room. So then the next thing that's going to be important is, one, to communicate with infection control, obviously, but two is to protect yourself when you go in to interview the person. So wear appropriate PPE, including gowns, gloves, eye protection, and N95 respirator. So that would protect you if it's MERS, measles, or Ebola. Also would do a good job against things like influenza. And then obtain a 30-day travel history, find out exactly where they went and what their risk factors were. Did they have contact with someone that was sick there with one of these illnesses? In terms of what exact countries different outbreaks are going on, the CDC travel website has all that information, or you can contact the health department and we can help you figure it out. So actions, obviously keep the person in an isolation room, contact infection control and public health, and then request an infectious disease consult. I wanted to just mention Middle Eastern respiratory virus, respiratory syndrome, coronavirus infection. One reason is because currently the Hajj pilgrimage is occurring right now in Saudi Arabia where this outbreak is occurring. Up to 30 million people from around the world attend this event, including an estimated about 11,000 Americans every year. So these people could be traveling there and then coming back. So currently, Middle Eastern respiratory syndrome, it's a disease similar to SARS. It's a coronavirus, started in 2012, associated with countries around the Arabian Peninsula. And it causes a respiratory illness, again, similar to SARS. There's a high case fatality rate, about 30%. There's been about 700 lab-confirmed cases and 200 deaths. The spread is through close contact, so primarily caregivers and healthcare workers are at most risk. There's no evidence currently of sustained spread in the community, and again, all cases have been linked to the Arabian Peninsula. So these are the countries where there's been outbreak cases occurred, but there's also a large list of countries where people have traveled and traveled back to from those areas with disease, including the United States. So back in May, there was 2 cases of MERS and people from the United States that had traveled to Saudi Arabia. So again, people at risk, obviously recent travelers. The incubation period is 14 days, so people that have traveled within the last 14 days to Saudi Arabia that have febrile illness or who have contact with a sick traveler from that area. And again, infection control should include airborne precautions because MERS, unlike Ebola, is airborne spread. I also just wanted to briefly mention measles again. Big outbreak of measles in the Philippines, 44,000 cases with almost 100 deaths. And there's been 22 U.S. citizens that have traveled there and come back with measles, including cases in Tennessee. So again, just heightened awareness about, it's always a good idea to ask about travel history in someone that's febrile. I think y'all teach your residents and fellows, it's one of the first questions you ask when you're evaluating a febrile person, travel history. So now I want to discuss, any questions about MERS or measles? Right.
Not equipped, so would it be possible for the DC Department of Health to send like EMS personnel that are trained to retrieve such a case upon its presentation to the emergency room, and then take them to a bigger hospital or that is equipped to be there?
Yeah. So the question is, what if someone shows up at a small hospital that's not really ready to take care of someone? So hospital systems are planning, I know for sure Misha's planning. I know Wellmont's planning. And some of their smaller hospitals, I don't know the exact plans, but I'm pretty sure they're not planning to take care of these patients at the smaller hospitals. We have had meetings with EMS about 911, people screening people that call in with fever for travel history, and also EMS personnel to know to ask about travel history in someone that's febrile so that they can wear the appropriate level of PPE when they transport somebody. But yeah, definitely transfer is an important consideration.
Would they take them right away from, say, Sycamore Grove or
Yeah,
Franklin Woods, APR, just take them to the big house?
right. Yeah, and definitely in consultation with the health department, we'd want the person taken care of in the best possible place. So this is an algorithm, and these are printed in the back, but these might be good to have posted everywhere that your folks are doing clinical care. But it's the CDC Ebola virus disease algorithm. So if someone presents with fever, either subjective or greater than or equal to 100.5, so I'm not sure exactly why they put a number on there, because if someone was 101.4, I probably wouldn't let them go home if they had the appropriate travel history and things like that. But anyway, so if they have fever and travel in the last 21 days, again, that's the incubation period. There's a few scenarios you might see. You might have someone come in that's totally well and no fever, but they've traveled and they've been watching the news and they're just really worried, which we've actually seen, in which case have those people get in contact with the health department or call us while they're there, and we'll come talk to them. Because one of the things we want to do is educate them about monitoring their symptoms. We would likely be in touch with them every day, just finding out how they're doing, and at the first signs of illness, kind of do a controlled admission to the hospital. Rather than have EMS go out there and not know what the situation is, we would kind of arrange everything in terms of transport and also give the hospital a heads up, maybe some time to get ready. So you can have worried well that have traveled. You may have worried well come in that's never traveled anywhere, so just some education there. So then fever and travel to the affected country. So if it's yes to fever and yes to travel in the last 21 days to one of the countries affected by the outbreak, again, isolate the person in a private room with a private bath. It may be the isolation room in the ER, and you'll have to move them later. And then whoever's evaluating them has to be in the appropriate level of PPE, which we'll talk about more. Notify infection control, contact the health department so that we can start looking at contacts if the person actually is a suspect case. And then evaluate for any risk exposures so that they have high risk, low risk, or no known exposure. Maybe they were a missionary that was actually caring for somebody and had a high risk exposure. Maybe they had gone back and shaken hands with someone that they've since found out has Ebola. So they'd kind of be in the low risk category because it's just kind of casual contact, or someone that's traveled to the country but had no known contact with anyone with Ebola. So different risk categories. So they would fall into, depending on severity of illness, I think if they have any illness and they've had travel in the last 21 days, I would put them in the suspected category. But CDC has that not suspected category. I would say not suspected only if they either didn't travel to those countries or they don't have any symptoms at all and no fever, so they're totally well and just worried, then just report those people to the health department. So if you do have a suspected case, again, contact the health department so we can arrange testing, which will have to be done at CDC. And health department in consultation with CDC will provide guidance. Again, testing not indicated, I would say only if either they don't have any symptoms at all or they did not travel to those particular countries in West Africa or had any contact with anyone that's traveled to those countries. So a scenario, this is part of the hospital exercise that we did on Friday with all the area hospitals. So 23-year-old presents to the emergency department with fever, muscle pain, and headache. Basically, how would the ER registration handle a patient with flu-like symptoms, so nonspecific symptoms? What symptom-related questions would be asked, and what travel history questions would be asked? So probably before now, maybe no travel history questions were asked, but we're recommending again to 911, EMS, any healthcare providers that's seeing febrile patients at this point. It only takes a couple of seconds to ask if anyone traveled internationally. So screening everyone with a fever for history of travel. I think you probably heard on the news that the patient in Texas actually presented to the hospital. They actually did give a history of traveling to those areas, but the ball was totally dropped, and no one told anybody. Whoever got that history didn't, tell the appropriate person. So the person was, they said on the news, the person was told they had a viral illness and discharged with an antibiotic. So there's like multiple public health things wrong with that picture, but we don't want to be that scenario here, obviously. So travel history, upon further investigation, it's learned that the patient's illness started with fever. He just recently returned to attend college. Patient stayed in his dorm for 3 days, feeling sick before he presented to the emergency department. So actually his travel history was that he came from, somehow it got erased from the presentation, but came from Sierra Leone and traveled back to attend college here in Tennessee. So at this point, what isolation procedures would be enacted? So if you remember the algorithm, put the person in an isolation room, step out, put on the right level of PPE for yourself before you go back in and do an evaluation. Also make sure you contact infection control and the health department to alert everybody. We have had situations where patients have come to the ER here where, when they called us, we just came over to help the ER evaluate them, and we'd be happy to do that again. Obviously, it was a worried well person, else you'd have heard about it in the news, but we're happy to come over to help with the evaluation. Then kind of a question, how will you move the patient if necessary? So hospitals are planning on, how to get the person from the ER to their isolation room, so they're going to take care of them. Or if it's coming by EMS, do you have them come in the back door, and have security just clear the hallway and take them the shortest route? And then who needs to be contacted with this information? Obviously, infection control, infectious disease, hospital administration, and health department. So here's the travel history. Patient was on a mission trip to Sierra Leone. Someone that he had contact with, he since learned died from Ebola. So now how are we going to diagnose this patient again? This person's been traveling in Africa. It could be any number of infectious diseases. So again, the PCR test, which has to be done at CDC, may take up to 72 hours to be positive. So in the meantime, keeping the patient in isolation, using all the precautions you would if you'd actually had Ebola. Also trying to rule out other things like sepsis or malaria that could kill them while you're waiting for the Ebola test to come back. Performing routine laboratory tests. So the CDC recommendation is that you can perform routine labs using your routine laboratory equipment. The important thing is that everybody along the chain has to be wearing the appropriate PPE. And there is some concern nationally that laboratory workers have become a little lax in using appropriate PPE when they're doing laboratory tests. So we do recommend, and we have recommended all the hospitals to do walkthroughs of their laboratories to look for trouble spots. Laboratory workers, again, should be wearing the same level of PPE as the person taking care of them at the bedside and the person doing the phlebotomy. One of the things we also recommend, besides the walkthrough to look for trouble spots in the lab, is to have what we call the buddy system. So with PPE, have one person doing the procedure and someone else also in PPE, kind of observing them to make sure that they don't contaminate themselves without knowing. And we'll talk more about that in a minute. Environmental cleaning, again, whoever's doing the environmental cleaning has to be wearing the right PPE. Ebola virus is not a particularly hardy virus, and it can be killed by all the things we use in the hospital to wipe the beds down and do environmental cleaning now. So any EPA disinfectant that works against non-envelope viruses, which is the stuff everyone's spraying and wiping down the hospital with right now. 10% bleach will kill it. Ultraviolet light will kill it. How would you manage and dispose of waste? So obviously, you want to be very careful. So the person taking out the garbage also has to be in the right level of PPE. I think at Emory University, they actually autoclaved in some big surgery autoclave all of the waste before they took it out. All the body fluids. Yeah, so the body fluids, CDC says you can just flush them and that sanitation will take care of it. At Emory, they were pouring in disinfectant to the bleach with the body fluids before they flushed them.
We have a good question. Some of the hospital are having trouble with the disposal company.
Take the stuff.
Yeah, I heard the vendor at Emory
Yeah, the vendor had to have CDC come and do it, and they were going to.
Oh, really? I haven't heard that, but obviously that would be a case where you get in touch with the health department. We'd have to do some arranging. But that might be when they started autoclaving their garbage or something like that. The one concern some people have with pouring the bleach in is that you don't want to dump fluid in and have it splash up on you, so you have to be careful with that. The other thing is actually flushing the toilet can be an aerosol generating procedure, as we saw with SARS. There was a big outbreak in an apartment complex in Hong Kong related to when people were flushing the toilets, the SARS virus was getting aerosolized by the turbulence of the water. So that there are some concerns there. So what contact tracing questions? So obviously the health department's going to be involved, finding out who all this person had contact with after they became symptomatic. Then healthcare contacts. So there's a question about healthcare workers that are taking care of the person, what to do with them. Currently, CDC says as long as they're monitoring their symptoms and are asymptomatic, they can do their regular job duties. Hospitals may decide to do something else like furlough or sick leave and things like that. So transport, CDC's recommended transporting to a different hospital for treatment. How are we going to get them prepared? So, one of the other things is, people saw when the doctor arrived, there was that video of the doctor getting off the ambulance and going into Emory, and the patient actually was dressed in a Tyvek suit, and people were asking what that was all about. So one thing is apparently they had concerns about, because the patient had been having diarrhea, so they put the patient in a Tyvek suit so that if he did have an accident during transport, the fluids would be contained within the suit until they could get him in the isolation room. So transfer, you worry about, you obviously want the person to come in contact with the least amount of people, so whoever's transporting them has to be in the right level of PPE. You may decide to put the patient in a Tyvek suit or something like that for transport. There's some resources. All of these are, again, photocopied and they're outside the door and back of you. But the CDC guidance for fever and travel, very important as steps for putting on and removing personal protective equipment. So we think that most healthcare providers are probably contaminated at the point when they're taking off the PPE. Because the PPE is protecting you the whole time you're interacting with the patient. But if you do not take it off properly, there's risk for contaminating yourself. And we'll go over that guidance in a second. And then the CDC Ebola algorithm, which we went over just a minute ago. So the CDC has a checklist for preparedness for hospitals. And again, that CDC algorithm that we went over, again, we talked about that with EMS and 911. It's important in emergency departments. Any place that's seeing ambulatory patients that might come in with an acute febrile illness should be thinking about asking travel history questions. And if it's positive, either they know the guidance or they get a hold of someone that knows what to do next. I think we pretty much covered this, but if someone does have a febrile illness and they have traveled to these areas and potentially had some kind of exposure, they would be considered a person under investigation. Again, it's going to take some period of time before we can test them and confirm or rule out Ebola. But communication is key. Anytime something breaks down, like that person that evaluated the Dallas case that obviously didn't communicate it to the right person, and the person was discharged from the ER. So make sure that we're talking to infection control, hospital administration, and then state and local public health, so we can facilitate testing and contact tracing. Even if it turns out not to be a case, even if it's just a suspect case, or even a worried well, like I said, worried well people, we would just educate them about monitoring their symptoms for 21 days. We also recommend they don't take public transportation during that 21-day incubation period in case they become febrile in the middle of an airplane flight or on a train or something like that. And then we would just talk to them daily to make sure they're doing fine. And if they're not fine, to kind of coordinate a safe transfer to the hospital. So laboratory again, CDC says it's fine to do routine laboratory testing on your equipment, which should be safe for doing things with infectious diseases like HIV. So it should be safe. It's just, again, there's that question about whether laboratory workers are lapsing a little bit in their use of PPE nationally. So it's good to do a walkthrough, also retrain all the laboratory people. And again, environmental infection control, just standard disinfectants that work against non-enveloped viruses, wearing appropriate PPE. There are some questions at different hospitals about what level of PPE. So again, the CDC recommends impermeable gowns and not necessarily Tyveks. But I think a lot of people have seen healthcare providers wearing Tyveks and have questions about it. One of the reasons, especially when you see people in Africa taking care of patients in Africa wearing Tyveks, is that the situation's not very controlled there. So you have a tent that's not very big with 100 Ebola patients that are kind of laying on the floor and walking around, things like that. So it's a little bit different than in a hospital situation where you have one person in a private room that's in the bed, and it's a lot more controlled environment. So they just recommend an impermeable gown, gloves, eye protection, and a face mask. But they say that you can use additional PPE under certain situations. So if the person's having a lot of vomiting or diarrhea that you have to clean up, they recommend things like shoe covers and boots and things like that. And then also if there's any concern about aerosol, wearing an N95 respirator instead of a face mask. And then of course, doing a lot of hand hygiene. Any questions about PPE? We'll talk a little bit more about putting it on and taking it off, but any questions about what the recommended PPE is? There are some concerns. Tyveks covers more of your body, but it's also hot, and there's concerns about when you get all hot, you're going to sweat, and you're going to want to be touching your face, which is the absolute worst thing you can do. And then the other thing is taking Tyveks off is not that easy, so there's risk for contaminating yourself trying to get that Tyvek suit off. So PPE training is important, how to put it on and take it off, the right order for putting it on, and how to take it off without contaminating yourself, doing hand hygiene after each step, and then again the buddy system where you have at least two people there, so one person to watch the person put it on and take it off safely and to advise them if they've somehow contaminated themselves. So CDC has these recommendations for the order to put it on, so gown, then mask, then face shield, and then gloves. And again, the most important thing So the other recommendations: keep hands away from face, limit the amount of surfaces that you touch, change gloves when torn or heavily contaminated, and then perform hand hygiene frequently. Taking it off, the order is that because the gloves are the most contaminated item, that you take those off first by only touching the, the first glove you take off, touching the outside with the other glove, pull that off, and then slipping your finger inside the other glove, and then taking them both off. Then you take off the rest of the PPE by only touching the back, the part that's least contaminated, so the goggles or face shield by the back, and then the gown by untying it in the back, and then taking it off, trying only to touch the inside of the gown, the non-contaminated part, which actually takes some practice. That's why they recommend people practice the PPE. So getting the gown off without contaminating yourself takes some practice. And then finally take off the mask or respirator, again, trying to only touch the back of it, and then put all the disposable things into the garbage. It's also important to wash your hands between each step, particularly if you've touched something that may be contaminated, and then, of course, hand hygiene at the very end. So that's the last step, is the hand hygiene. Questions about putting on and taking off PPE? Has anyone ever practiced putting it on and taking it off? How many people have been fit tested for an N95 respirator? So about maybe 2/3. So, really the first time you put it on and take it off in that order, you don't want it to be after you've had contact with the patient. People will be nervous. It's always better to have some comfort level doing it. And again, that's probably the critical step, is taking off the PPE when most people probably contaminate themselves.
I just want to mention that what you just said is perfectly right. There's no way to put on the piping suit and take it off without an assistant.
Yeah, it's very tough.
One person's definitely lead to contamination. So
Yeah, it's very hard. CDC doesn't even have recommendations for taking off Tyvek suits. They don't necessarily recommend them. If people want to use them, they refer them to the manufacturer's instructions for taking them off. So isolation, again, airborne or other isolation room. It doesn't necessarily have to be airborne. I think most people are going with airborne because that's their isolation units are all airborne now. And then signage, so people, you don't want the janitor to walk in, doesn't know that's what what's going on in there necessarily, and just routinely comes in to take the garbage out or whatever, or the food service or something. And then obviously restrict access. So exposed healthcare workers, so if people are wearing appropriate PPE, CDC considers that low risk, and they can go about their regular job duties as long as they're monitoring their symptoms twice a day, taking their temperature twice a day and monitoring symptoms. If someone has exposure without appropriate PPE, or obviously get something like a needle stick, that would be a different situation in which they might be off on sick leave during that 21-day incubation period, or have other work restrictions. So take-home messages: look smart, get a travel history from febrile patients, protect yourselves and others. So isolate the patient and then put PPE on yourself. Again, practice. So a lot of this stuff's going to be hard to do, especially the PPE. When you're nervous, you're in a high-risk situation. So practicing ahead of time is good. And then communication, the thing that always breaks down in any kind of emergency situation is always communication. So make sure you talk to the appropriate people: infection control, public health, infectious disease consultants. And that is my contact information. So if there's questions now, or if you think of questions later, you can contact me either by email or telephone, or if you have a person that you're evaluating that you need help with, feel free to call. Health department does have 24/7 someone on call. If you call the local health department, you'll get a number to the on-call person. So, any questions about Ebola or Ebola preparedness?
I've seen the picture of the virus in the media for a long time.
It's non-enveloped. I'm sorry.
Is it DNA, RNA?
RNA.
Yeah, it's RNA virus. Yeah. Again, the virus itself is not environmentally that stable. In terms of, they've done some studies about contamination of the environment. So when they've looked for it by PCR on like the clothing and the bed sheets and things like that of an Ebola patient that's died, they've not found it on the clean parts, of the clothing and the bed sheets, but things that are contaminated with blood or soiled, with feces and things like that. That's where the virus is. It's thought not to be that stable in the environment, so after several days, it's going to die just from exposure and things like that if it's on hard surfaces and things. But, you don't obviously all the recommendations are for the highest level of safety. So, making sure you have PPE when you do any of those items, including housekeepers, environmental people that come in to clean and all that stuff. Of the PCR test?
Yeah, and second question is, I know we have to send sample to CDC, but are we going to have a lab that
Yeah, I haven't heard if the state lab or if or when they're going to have the ability to do it. I think it depends on how widely the outbreak, how many cases we get. I don't know the sensitivity and specificity, but I think it's pretty good with the PCR. They're both of those are pretty good with the PCR test.
Mortality numbers thrown out there before, and I never really thought about were those considered in like a first world treatment area or third world. Is there a big difference there? You think? Do you have any kind of estimate?
Yeah, so there's not a ton of data, because almost all of the outbreaks have occurred in places with really poor health infrastructure and public health infrastructure. But I think there's every reason to think that supportive care, in a hospital in the U.S. is the mortality rate will be a lot lower. Because, basically people, they're lucky if they're getting IV fluids right now in these tents. There are some, I think Doctors Without Borders isn't even doing IV fluids on the patients there. So the mortality rate's actually like, in some of the places is as high as 60 and 70% in these places with just these really poor conditions. The other thing is, all the other outbreaks in history have occurred in like the middle of nowhere, like in these really rural areas that are hard to get to. So they've kind of almost petered out on their own with some public health intervention. The problem now is that it's in this really big city, in a really populated area, and apparently it's also the rainy season, so everyone's indoors with close contact and things. So. Yeah, doing poorly. Probably not a good sign. Yeah. Yeah. So. Yeah, I don't know. So I haven't seen that from CDC because our health department people are asking for that to put up in our health department clinics too. But there are reminder signs for clinicians to hang up in their area with the criteria on who to call if it's positive. So there are those templates that we gave out to all the hospitals on Friday. But I think it would be good signage. If you have fever and you've traveled anywhere in the last 30 days, please advise the receptionist. Okay. Okay. Well, I should contact Jamie Swift so we can copy your signs and put them up in our health departments. There is a sign. There is a CDC sign about travel. So it says Ebola if you've traveled, like in the last 21 days, 3 weeks. Call your doctor if you get sick, kind of thing. But good point.
I've heard stories of the survivors who to help with survivors with communities. Can we be confident that survivors are not being infected?
I think the jury's not totally out on that, but I think CDC's hopeful. Supposedly there's about a 10-year period when they think that people will be immune. But I think they must not have all the data in, because one suggestion was that you could use those people to obviously care for, in the hospital where you have all these really sick people to care for the other people. And there has actually been some of that occurring already. There are some survivors that are going back and, helping in the hospitals take care of people. So there is thought that people have some immunity for 10 years following infection.
You know what they're using as vaccination, still virus, or
Yeah, I don't know specifically what the vaccine candidates are at this point. The one treatment that they're using is an antibody preparation. The treatment that the 2 people at Emory got is an antibody preparation. But again, that treatment has not been tested or in any kind of trials. As far as I know, at one point there was 4 people that had received it, 2 of which died and 2 survived. So you don't know if it did anything at all, really. Yeah, ZMAP.
as a local community, do we focus any of our efforts towards the source of the problem in Africa?
Yeah, definitely. The longer the outbreak goes on in Africa, the more chance, obviously, we need to help just because, how bad it is in Africa, help them. But also, the more chance it is that there's going to be a traveler that comes in contact with someone that's affected and comes back. Now that we have 1 or 2 people from our state health department that are in Liberia right now trying to help set up a surveillance network. We also have one of our students from ETSU that graduated from the public health department last year. She now works for CDC and she's heading to Monrovia, Liberia. So it definitely is important. There's been a lot of criticism that if we would have jumped on this a lot sooner, obviously it wouldn't have been as bad an outbreak there, and there'd be a lot less chance of it spreading to other countries. Yeah. I think people were a little complacent because previous outbreaks, were in these isolated areas and just never really got legs and got that big. So we are doing outreach to the community here. We do know that there's people from our area that travel back and forth to West Africa, so we've done some outreach to those folks to educate people about if they are travel. Well, for one, there's travel warnings, so avoid non-essential travel. But if you do travel, when you come back, contact the health department, monitor your symptoms for 21 days and things like that. We also know that we have students, at the university from these areas too. So student health has also been involved with educating, students about monitoring their symptoms and getting in touch with student health when they return. Also faculty that travel there. All right. Well, I appreciate your attention, and remember the take-home messages.